السلام.
عليكم السلام.
وعليكم السلام.
معليش انقطع من عندي الاتصال بس. دكتور فريد، انت تكلمت عن انواع الريبير وعن الرينج والريجيد والسوفت رينج. ف what I know that there is no difference between all type of ring, whether soft or rigid, except in a retrospective study was done in patients with ischemic heart disease, mainly secondary MR, ischemic MR. كان البابوليشن cabbage plus moderate or more mitral regage. They found in their study that the mitral valve degree was less with a rigid ring, plus the recurrent rate of mitral regage. Although this is not the common practice I saw, and some people they claim that the rigid ring can increase the rate of dehiscence, but this is the only study I came through in regarding type of ring. Otherwise, it's just a surgeon preference.
احنا كنا نتكلم على المايكروفال ريبير في الروماتيك.
ايش؟
كنا بنتكلم على المايكروفال ريبير في الروماتيك هارت ديزيز.
Rheumatic, yeah. For rheumatic heart disease, there is no difference between putting a rigid ring or a soft ring, and it's a surgeon preference rather. And you know, each one of them they have its own benefit.
اوكي.
Okay.
طيب اتفضل يا امجد.
So if we're talking about a rigid ring, it's a better remodeling, but as we said, it can cause, especially in rheumatic valves, rigid and complete ring can cause some sort of valve stenosis along with dehiscence. So each one of them has its benefit and risk. And at the end, there is no studies based on this. It's just a surgeon preference. Thank you.
السلام عليكم. الصوت واضح إن شاء الله؟
اي واضح صوت.
أوكي. أنا أمجد برنامج كاردياك سيرجن ريزيدنت في الإيسترن بروفاينس ساوث بابتين كاردياك سنتر as a junior resident. Today I'm gonna talk about re-operative valve surgery, which I'm honored supervised by Prof. Dr. Yasser Al-Ghunaimi, and he's with us. Okay. The outline like the following: introduction through the re-operative valve surgery, mechanical versus biological valves, just in short sentences, risk factors, imaging, aortic valve and aortic valve bypass surgery. And in each topic, we're going to talk about the redo sternotomy, different techniques for each valve, mitral valve, tricuspid, and we'll finish up with the summary. Okay, first of all, as an introduction, these reoperative most commonly involves structural deterioration of bioprosthesis versus the progression of native valve disease. Difficult than primary operation because of dehiscence around the heart, for sure, because of the tough tissue will be formed. The presence of more advanced cardiac pathology and excess of more frequent comorbidities such as pulmonary hypertension, descended RV, etc. Reoperative valve surgery considerably has higher operative mortality than primary valve surgery. Also, reduction in operative risk and post-operative morbidity by proper use of deep hypothermic cardiac arrest, in addition of use of peripheral cannulation technique. Cardiopulmonary bypass prior to the re-entry prevents the injury of the RV, or patent coronary artery bypass as in previous cabbage. The risk of replacement for bioprosthesis failure remains a significant factor to be considered in selection of valve type for implantation. Mechanical valves versus biological valves. For each individual, it depends on case by case. So the age will play a big factor, life expectancy, lifestyle, valve size, and cardiac as well, or non-cardiac comorbidities for sure. Some studies comparing the long term of biological versus mechanical, they found that the similar result regarding the overall valve-related complication. However, most recent large studies documented the anticoagulation-related bleeding for the mechanical valve must be balanced with the relation to the biological valve replacement. Bioprosthetic valves are known to undergo a time-dependent process of structural deterioration like the native valve. So in the freedom of free operation of 80% for 15 years period, that's the time limited. But again, the favor of bioprosthesis is to benefit with the valve-on-valve replacement. So mechanical prostheses usually are selected for younger recipients because of the proven durability over the time. The risk of anticoagulation-related bleeding as well as thromboembolic events. These valve, it's in trivial or small minimum on valve design, structural materials, and host-related interactions. So also in 12 years, the study documented severe bleeding complication in 18.6 versus 7.1%, respectively. In addition to endocarditis, dehiscence, perivalvular leak, venous formation, it's the similar with the mechanical and bioprosthesis valve. But mechanical valve durability with the associated risk cannot be ignored. This is the outweigh balance in according to the failure rate to the bioprosthesis and reoperation. Next, so I'm gonna talk about the risk factor for reoperative valve. The mortality was 7% for second reoperative procedure. It will double with the third reoperation. The mortality in first reoperation in one study found with 530 patients was 5.9% in the aortic position and 19.6% in mitral position. In aortic position, operative mortality was 2.4% for NIHA class 1 and 1.6% for NIHA class 2 and 6.3% for NIHA class 3. 20.8% for NIHA class 4, that's emphasizing the significance of early referral for the patient. Regarding the urgency on the mortality in relation for elective mitral valve reoperation was 1.4%. For urgent procedure, that would be 8%. And for the emergency procedure would be 37.5%.
Amjad,
أيوة دكتور فريد اتفضل.
do you want us? Can you ask? Can we ask questions, or shall we wait until the end?
Yeah, please. No, please stop me at any point.
Okay, come back one slide, please.
Okay. Here.
I can't see it yet. Okay, so can you explain that the no, go back, go to the front. I mean, go one slide forward.
To the front. Okay.
Yes.
Stop. Next, please. لا أنت بترجع ورا كده.
ممكن.
Okay, stop here. Stop. Okay, stop there.
Okay.
خلاص بلاش. You just mentioned that it's for NIHA class 1, it's 2.4, and for NIHA class 2, it's 1.6 mortality rate. How can you explain that?
I didn't understand your question.
Okay, you just said in the aortic position, the third statement, operative mortality was
Yes.
2.4% for class 1
Mhm.
and 1.6,
Yes.
which is less for more disease, less for NEHA class 2.
Mhm.
How
Yeah.
can you explain
So
that?
actually,
How
I
can you
don't
explain
have an
that?
explanation. I don't have an explanation for it.
Okay, think about it. Everybody really, all the juniors should be able to answer that question. Just go on for the next continue your presentation, please. Thank you.
Okay. So in another studies of in the Jones and his colleagues series, mortality increased from 3.0% for re-operation, a new valve site, 10% for prosthetic valve dysfunction or periprosthetic leak. Mortality was highest as 29.4% associated with endocarditis or valve thrombosis. Cabbage carried the higher mortality rate, reached up to 15.4% than when it was not required, in 8.2% in that study. Among the 336 patients requiring replacement of prosthetic valve, mortality was 26.1% for re-replacement of mechanical valve, compared with the 8.6% for replacement of tissue valve. So, in conclusion, for this study, what the multivariable analysis, a significant predictor for mortality that will increase with in re-operation surgeries, will increase with patient age, indication, concomitant cabbage, and replacement of mechanical valve rather than tissue valve. So in this table, we'll sum up the risk factor. So advanced age, impaired ejection fraction, the NEHA classes, as we mentioned in that study, the urgency or emergency of stability of each case, the preoperative cardiogenic shock, or also, as in Jones' study, we mentioned that in cabbage, the mortality rates reach in up to 15% in presence of previous cabbage. Prosthetic valve, endocarditis, surgery for paravalvular leak or valve thrombosis, prosthetic dysfunction. And finally, the organ failure, renal or COPD.
Amjad,
Yes.
which one of this in the list is the most has the most serious impact on the outcome?
The most in the list.
The most serious
impact
Yeah.
for the reoperative. Actually, I cannot say one. Yani, it's a multiple factors. But if you want me to choose one, only one.
You have to read about it. If you don't, يعني ما ابغاك تفتي هنا تقول لي والله احذر ولا كده. If you know it or you go and read about it.
شكرا. على فكره يا بروف، ده سؤال MCQ فعلا بيجي في البارت 1 والبروموشن.
لا على فكره انا مالي اي دخل بالاسئله حقت الامتحان ابدا.
لا بقول لحضرتك في اللجنه، فانا
يا بنبه عليهم عشان لا يحسبوني اني بغششهم ولا شيء. الله المستعان.
لا
But this is a very
هي
important
نقطه انا عايز اقول لحضرتك انها very important point، يعني it's very important point الحقيقه.
Okay, if I answer now, you would tell me if it's right or wrong?
No.
طبعا لا.
Okay. I have an answer, but okay, I will read about it again also. Okay, so the preoperative imaging for the reoperative surgery, the standard preoperative coronary, like the usual, and the chest X-ray wouldn't benefit here in Re-operative, because mainly we are looking for the graft, we're looking for relations of organ to the sternum, like the aorta, the RV. That would help us a lot on the technique or during the surgery. So the retrospective ECG gated multi-detector CT scan will have a role here as a modality of choice for location of the heart and relation of the sternum, as I mentioned. So pre-operative CT scan will lead to modification of surgical approach in 20% of patients undergoing redo cardiac surgery. Those pictures I brought from the internet for the CT, the multi-detector CT. So in this picture here, 57-year man with the rheumatoid LAD graft. So we can see here in the yellow arrow the rheuma graft, how it's close to the sternum from here, and this is its continuation. So it would help us a lot in. And here we can see the pulmonary artery and the RV also here, how much it's close from the sternum. In the other picture, there is the lima to LAD here. This is the lima, and as in continuation here also from the sternum here. And this is in axial CT. We can see here the graft, the lima to LAD graft, very close to the sternum, almost adhere to it. And this is another thing as coincidence myxoma finding in the CT. So pre-operative, next topic will be about the re-operative aortic valve surgery. In the past, the aortic valve replacement was in favor with basically 3 points: is the presence of well-established contraindication to, of a bioprosthesis valve, aortic valve replacement, in favor with 3 main points, which are the presence of well-established contraindication to anticoagulation, the inability to monitor the prothrombin level adequately, the patient who are survived with the limited, more dependent or non-valve related issue. So emergency re-operation yield a high early mortality rate, reach up from 25 to 44%. The incidence of lima injury in the literature varies from 5 to 9%, and it's associated with a 40% risk in perioperative MI and 50% mortality rate. The most traditional approach is the median sternotomy with dissection of the graft, of the lima to LAD graft, and occlusion with the bullock. So then the aortic cross clamp carried on. The advantage of this strategy is the short cardiopulmonary bypass, maximizing the uniform myocardial protection with the cardioplegia washout. But obvious risk of lima to injury is high. So the other technique is the no dissection technique, which you will the graft of will lift unclamped. The aorta will not be clamped, and we will put the patient in deep hypothermic cardioplegia. So the advantage of minimizing the dissection of the graft, but not eliminating the risk. The other thing is the disadvantage will be, in the other hand, is that the unclamped lima graft will be uneven myocardial protection because of cardioplegia washout from the territory of the lima graft. Also, the poor visualization, which will bother during the operation. This maybe can be with the deep hypothermic as in low as maybe 20 degree, maybe can help, but it's still. Also, we have the supraclavicular or the endovascular control for patent Lima graft. In addition, it was worth to mention the other strategy of handling the patent Lima graft involves the deep hypothermia, as we mentioned, without controlling the graft and or cross clamping. This technique occasionally indicated patient with porcelain aorta. This is another technique. Back to the no dissection technique, the hypothermia quadriplegia is preferred approach for the redo. So several studies have documented that the safety of this method without the increase the risk of preoperative mortality. Okay. For the conventional resternotomy, I have a video here that I will play, and then we'll go back. So this is a video for resternotomy, redusternotomy, I mean. So after the dissection, usually we'll start from posterior edges rather than the anterior, and we'll dissect very careful with the cautery, and we'll use the heavy sutures to lift up the sternum instead of doing sharp dissection and injure any deep structure. So we'll use also the oscillating gas saw instead of the regular saw, so that will help us in the dissection and not to injure the RV easily. So it will be like soft and very careful. Also, one thing that in yeah, now we are doing. I'm going to the video, then I will explain the other stuff. Here we can use the scissor to dissect more. We can go very carefully with the dissection, all because of the adhesions of the tissues, because of the redo. Or we can get use of putting dry gauze on the back, so it will dry up the field. And when continue from posterior to anterior. I will go further with the video, so not take. Also, we'll continue dissecting. Then we'll release up the sternum from the pericardium by with the traction. We'll try to get use of the traction and the contraction of the with the blunt dissection with the cautery and traction rather than go more sharp to avoid the injury of the RV. So I think it's finished. Okay, now I'll go back. So for the conventional, sorry?
Sorry, can I interrupt?
Yeah, please.
Regarding, because you mentioned that patient with intact Lima with and
Yeah.
the AVR. So from what I understand, patient with intact Lima, and most likely that he did his cabbage 50, 55, 60-year-old. So we just now also again we have the TAVI. So this particular example, I believe currently in this era, we'll go for TAVI, not for redo everything. In the context of that the patient is having intact edema, that means he have or had cabbage at the age maybe 60, above 50, then he needed AVR at 60 or 65. I'm just assuming the scenario. Also, before going to the histonotomy, and the most important is to go through the plane that you created, as you said, from posterior until anterior, and not to injure. You need to see where you are going with the I mean the histonotomy that you are doing. And there is a different technique as well for doing histonotomy. I believe you will also speak about the role of minimally invasive surgery later.
Yes, I am.
Okay, thank you.
Dr. Haitham, sorry to interrupt you. If you have a aortic valve, or you have a previous cabbage with aortic valve mechanical, so you have to open him, right? There are some indications where you will still do the redo aortic valve.
Yes, of course. Yes,
for aortic regurgitation.
Yeah. So we have to learn this. We need to learn these things. These techniques of redo in presence of particularly the patent edema is very important in terms of outcome. Thank you.
Okay. This is the steps of procedure, just not to forget that I left anything. I will just mention the point that I maybe missed, that the cephalic dysfunction dissection should be with the freeing innominate vein first with the retractor to avoid the injury. Further dissection also carried out through the superior vena cava, careful not to location the right phrenic nerve. Okay, then also the dense adhesion that will be formed in the right atrial appendage. Avoid the area where the aorta opposes the pulmonary artery, another site of potential injury, or which we call the deep ventilizing area. Small ventricular or atrial laceration should be not attempted before releasing the tension of the surrounding adhesion. What time is? Repair. Yes. To repair the great vessels injury or severe RV injury, it is best done with the cardiopulmonary bypass. Actually, is the best thing that we can do is to do the femoral cannulation first, and then you will go with the sternotomy. So just in case of RV injury happen, so you can start you can initiate the cardiopulmonary bypass, then you goes on with the dry field to repair the RV injury. So this is the point that I was to try to mention earlier. So in severe active hemorrhage during the second sternotomy, usually caused by adherence of the heart or great vessels, to prevent the complication of the interposition of the cardium or other mediastinal tissue. The incidence of hemorrhage between 2 to 6% in oral patient in Re-oprative. So also a report cases of patient of 552 patients who had undergone Re-operative prosthetic valve surgery. 23 patients, which 4% had complication of related direct sternal opening. Among them, the highest was lacerating of the aorta, was like 9 patients. Then the other with 7 patients with the RV, 5 patients the right atrium also, 5 patients, yes, and 2 of them they have previous graft injury. So 19 of the 23 complications occurred during the first operation. So in conclusion, for the injury of breast anatomy, the first death involved the division of previous placed coronary artery graft. And the second was caused by laceration to the aorta and subsequent great vessels. Sorry. So just to make the presentation more cooperative and interactive, if major hemorrhage happen, how we will react? I know that most of you know the answer. Just to make it more reactive, if major hemorrhage during the sternotomy, how we can deal with it? If anyone wants to share,
Can I answer?
please. Yeah, please.
So I expect that I already prepared the patient for such a scenario by having the femoral vessels marked and ready for cannulation, and I want to have the blood saver ready. So in case of severe hemorrhage during dissection and a redo case, I will first see if I can control it. It's like a controllable bleeding. I will just control it, and if not, I will put my sections and put the. I will give heparin and put the cell saver, and after 3 minutes, I will start sectioning the blood and see if I can control it. This is if the patient remains stable. If the hemorrhage is severe and the patient became unstable, I will just close the chest and go to femoral bypass and then repair the injury by the own.
Thank you, Doctor. Yes.
مرتضى
تفضل.
for this يعني for me if hemorrhage happened
Yeah.
I would notify first things the anesthesiologist with me. They need to be on board to bring the blood. I will close the chest, or if we can tamponate it with gauze, with anything, just to decrease the amount of hemorrhage. Then I will go for the peripheral cannulation that already prepared, go on pump. As you said, you will use cell saver. Once I'm in pump, I can use the pump sucker. Then I can control it best. I'm in what they call it, a control situation right now. I'm on the pump. All the blood that is bleeding, it can be returned back, and I'm losing nothing. Anesthesiologist on the board to give blood on the same time for the hypovolemia, because the patient will go for hypovolemic shock. But I will not attempt to try to see or to repair. And this is what I will do.
And don't forget to call for help. The first thing you will do.
Yes.
Yeah.
This is number one.
Yeah. So thank you all for sharing your answers. So yeah, as collectively as all of you said. So first of all, for sure, call of helps. Actually, the answer is of you, and the one that I found is more like with the situation that I had with the surgery. So that's why I put it as a question. It was like first time for me, and so RV while the surgeon was dissecting the sternum, and RV get and bleeding start to be everywhere, like in the surgery. So he was like shooting, like careful help more. I need more assistant, because we were like 3 in the surgery, and I was really shocked. So 2 of us like
He was shouting for help before the bleeding or after the bleeding?
after the bleeding happened, he shouted for help. So and 2 of us like were holding the sternum from each side. After backing of we brought a lot of pads and gauzes, and we back it inside, and then we two of us stand against each other, closing the sternum like we are closing the ribs with the wires. and the peripheral cannulation was not prepared. So the surgeon and the first assistant went down and they do the peripheral cannulation, the femoral cannulation, and we initiated the pump. Meanwhile, also we put, as Dr. Murtada mentioned, the cell saver suctioning the blood, because even when we are packing, still it's bleeding is happening. So then we initiate the cardiopulmonary bypass and we went smoothly. I was thinking like the patient is dead because this is the first time for me and seeing this. But yeah, alhamdulillah, the surgery went smoothly. The valve replaced very well, and he extubated and everything was fine with him. So that's if hemorrhage happened. Next, we're gonna talk about the minimal invasive for aortic valve replacement. So in points, let's put it for the aortic valve replacement in minimal invasive. So the routine exposure will be like peripheral cannulation. This is for minimal invasive. It will be a routine instead of like median sternotomy. And we'll place the defibrillator pads before even dripping using the intraoperative TEE in patient with patent Lima to LAD graft. Peripheral cannulation and cardiopulmonary bypass will be established, like we have mentioned. Mediastinal dissection will be limited to the ascending aorta for clamping and arteriotomy. And the right atrium only. If the right atrium is cannulated, only if the right atrium cannulated, I mean. So using of peripheral cannulation to be avoid in clutter in the chest. Use of vacuum assistant in cardiopulmonary bypass. Also, if retrograde cardioplegia delivered through the transjugular, or in addition to integrate catheter for plegia. Cooling will be at least 25 to 20 degree to, as I mentioned before, to avoid the territories of the Lima and 2LAD. يعني get the field very dark and you cannot go on for better visualization. If visualization is poor because of venting with the pediatric vent placed through the aortic cannula also. And finally, placement of temporary pacing wire and the right ventricle. So this is the picture, shows us how it's look like, the view. It's pretty much the view of the minimal invasive. This is the arteriotomy and this is the graft here. And this is the cannulation in the ascending aorta. So for the pre-operative aortic valve replacement after homograft or root or allograft, it is expected about 1/3 of patients younger than 40 years age will require aortic valve replacement within 12 years for the homograft. Sorry. And the feasibility of aortic valve replacement after full root replacement with the homograft. So in a serious study of 18 patients, full root and mini root and subcoronary techniques, all were amenable for valve replacement. Homograft replacement, non-lead is performed, but it's much less common in hospital mortality widely in many centers, ranging between 2.5% and 50%. Next modality or technique that I'm going to talk about during the valve, aortic valve surgery is the aortic valve bypass surgery. We can see the picture first, then. So yes, So this is basically the aortic, or let's just talk and then we'll elaborate more in the picture. What is the aortic bypass surgery? It's also known as an apical aortic conduit surgery, as an alternative high risk for inoperable patients, especially in the aortic stenosis. So the aortic bypass surgery, I cannot, for me, just I put it in my mind sometimes like the off bypass, but it's kind of, yeah, putting the LV, the conduit between the LV left ventricle and the apical part of the with the porcine aorta for severe prosthetic. Sorry. It is an pathway or an attachment between the LV and the aortic valve to just bypass in case to reduce the need of aortic clamp. So these patients with reduced LV function, porcine aorta, severe prosthetic mismatch, excessive comorbidities, and vulnerable functional graft, those will get in favor of this aortic bypass surgery. Also, the approach, as I mentioned, to avoid the cross clamp, the cardioplegia arrest, the cardiopulmonary bypass period, long period, debridement of the native valve, and injury of patent graft sometimes. Contraindication for this surgery will include moderate AI. So this surgery is basically for severe cases, for much high risk cases instead of moderate to cases. Relative contraindication will be if there is a problem with the descending aorta, because we are gonna do, as I mentioned, the conduit between the descending aorta and the left ventricle. So if there is diseased descending aorta, that will be make it as a contraindication. The procedure is performed using the left ventricle apical connector. Well, with the let's show us the picture now. Yeah, so this is the apical conduit. We'll use an aortic valve here, and we attach it to the descending aorta. Actually, the technique will be in thoracotomy, in left anterior lateral thoracotomy, in 4/5 space. So we'll do this conduit to just bypass the clamp of the aorta. Back to the details, I'll elaborate more. So using the left ventricle apical connector, as we saw in the picture with the silicone syringe ring and the hard valve, typically you will use the stainless porcine valve with the coronaries over soon. And all together will be sewn with the dacron graft as in the beginning of the procedure. An 8mm side branch of the dacron can be placed in case when we initiating the cardiopulmonary bypass, just if we need to, and what we can do with the partial clamp on the aorta instead of full cross clamp. The patient positioned in the right lateral decubitus, like we are doing thoracic surgery, with the double lumen ETT also, to exclude the apical thrombus. We'll use TEE, ETT for the intubation, but the TEE used to exclude the apical thrombus calcification on the descending aorta. As we mentioned, that will be contraindication for the surgery. If going on bypass, atrial and venous cannula are placed in groin. a 5th to 6th intercostal space thoracotomy will be performed to make the apex of the heart more free, along with the descending aorta. The valve conduit, the apical connector, and then oriented in the connector into the apex of the heart. After giving heparin to the distal anastomosis performed after replacement of partial occluding clamp on the descending aorta. This is for the pericardium, then opened and tagged up with the mark as 1 to 2 centimeter lateral to the true apex of left ventricle, just to put a mark on it. And then will be sutured with the 2O monofilament plegided suture used as an interrupted fashion around the mark with the deep bites nearly to the fullness. This is in the apex of the heart. Sorry. If the cardiopulmonary bypass to be initiated will be in this time while we're connecting the apex. The patient will be placed in the steep Trendelenburg position, and the ventricle will be based as 200 beats per minute to reduce the ventricle ejection. A hole will be made in the apical area with the 14 French Foley catheter is placed in the ventricle also to reduce the volume of blood. Tension is placed on the Foley catheter, and coring knife is used to remove a plug of apical myocardium. This part that gonna be removed will be like 85% of the diameter from the apical connector. Is selected to ensure the proper fit, optimizing the hemostasis with the connector. The Foley catheter is then removed, and the apical connector placed in the left ventricle. Then the suture will be tied down. Then the graft is de-aired and the chest is closed. So the studies have shown that approximately 1/3 of the flow travels of the native valves, whereas 2/3 travel out of the conduit. The procedure has been shown that highly efficacious, dropping the mean aortic valve gradient when studied from 43 to 10 millimeter. The durability of the apical aortic conduit procedure is apparent with some patients no more than 25 years from their operations. And this is the picture again. So next is the transcatheter aortic valves. Actually, we're gonna talk in short for the transcatheter, although it's the coming era of replacement, as Dr. Haytham is mentioning. So the transcatheter aortic valves is mainly we are using two valves, the Sapien and the Corb Medtronic valve. This is the Medtronic core valve with inflatable balloon, and this is the Sapien with the self-inflated balloon. So mainly for cases, for redo cases with the favor with the partner study for much of the cases. So replacement of valve, if there is no contraindication, there is no contraindication. I mean, if there is especially contraindication also for the median sternotomy, will be in favor for the transcatheter aortic valve replacement, especially if patients are putting also the tissue valve. So the transcatheter aortic valve implantation or VMV procedure, it shows in one of its studies in valve international data registry that established in 2010 that from 55 centers around the world, that they published that 459 high-risk patients that underwent VNB implantation with the largest serious data. They reported 30-day operative mortality of 7.6%. Only 1.7% of major stroke rate, 83.2% overall in 1 year survival, which is a high rate, I think. Of those who survived 1 year, 92.3% had good functional status. And that will be NIHA class 1 to 2, which is really good. Safety concern include device malposition, osseal or coronary occlusion, and elevated post-procedural gradient. The valve-in-valve international registry reported that high device malposition rate will be like 15.3%, and the 3.5% rate, the osseal coronary obstruction, and 28.4% rate post-procedural high gradient. And the mean will be like more than or equal 20. So this will leave us to finish with the aortic valve, and we'll move with the mitral. With the mitral valve surgery. So the mitral valve surgery basically have 3 techniques within, whether the median sternotomy, right thoracotomy, and the left thoracotomy. Also, sometimes the transverse sternotomy. So, but mainly the right and median sternotomy. So the left thoracotomy has been used in recent years, just an alternative for the right thoracotomy actually. If there is any contraindication, like if the patient has mastectomy or radiation or pleurodesis, for example, all that will leave us with the left thoracotomy instead of the right. Otherwise, the right will be in the upper hand. So the incision will be like the usual thoracotomy in the fourth intercostal space. The left pleural cavity will be entered in standard fashion. A strategy is performed in fibrillatory arrest, beating heart technique. What is important here is the orientation of the mitral valve will be with this approach will be the posterior annulus found anterior. So it will be, it's not like the usual to the surgeon. That the posterior annulus will be in the anterior instead of the right thoracotomy. In one study of Thompson and colleagues recently reported of 125 patients undergoing this technique. So 86% were in NIHA class 3 or 4, and 28% has undergone 2 or more sternotomies. 30-day mortality was 6.4% with low complication rate. Also, other modalities, as I mentioned, is bilateral anterior thoracotomy, like transverse thoracotomy, carried out through the fourth intercostal space, along with the nipple. Has been rarely used today. This incision is transect the sternum transversely, requiring the ligation of both, for sure, the left and right internal mammary arteries to save it for later on. So as for the mitral views will be the standard left atriotomy, being in blunt dissection of the intra-arterial groove. Let's see the picture again, and then So this is will be like the right arteriotomy here will be in the intra-arterial groove, and part from the atrial will be retracted with the suture to avoid the rupture. Will be here, like to give you a better view. So this is the right arteriotomy fashion. Also, we can go with the transeptal. We can mention later on. Oh, we should go back. So the left arteriotomy begins with the blunt dissection in the intra-arterial groove, as I saw, as I explained in the picture. The right superior pulmonary vein will be very close to the the right superior pulmonary vein will be much close. So we need to avoid the injury. Also, if we like taking deep sutures. The incision will be extended up and down, close to the SVC and IVC to give enough exposure through the mitral valve. We must avoid the posterior wall of the right pulmonary vein, as I mentioned, to avoid injury. Right atrial or transeptal approach has become, the transeptal approach become much popular in recent years, especially in reoperative valve surgery. After opening the right atrium, the intra-arterial septum incised, starting the fossa ovalis and moving vertically and few centimeters. We'll show in the pictures, I think. Yeah, here. This is a transeptal technique. Will be open. This is the coronary sinus, and this will open close to the fossa ovalis, so it will grab the left and right atrium on each side, and mitral will have a good view of it. And when we are closing the septum, as we are giving intro and retrograde cardioplegia, with the last stitch will leave it open for de-airing and to fill up the left ventricle with some volume, so that will de-air. Then we'll take the last stitch. This is what they are trying to say here in this picture. So, and this is for the right thoracotomy technique. For the resternotomy technique, the risk will be include the injury or the embolism for a prior graft, as we mentioned in the aortic valve, the same, sternal adhesions, excessive hemorrhage, and underwent cardiac injury. The atrial dilatation can result to significant cardiomegaly that will make more challenge for the resternotomy. The patient undergoing prosthetic valve reoperation have a 4% incidence of complication directly related to the sternal re-entry. That can result directly to intraoperative death. So in 4% can directly report to death. The area of patent phlegma still with high mortality, and this is actually I think answers Dr. Farid's question. Maybe this is what in my mind, that the cabbage and the patent phlegma injury, this is the high rate that can happen in the reoperative, if I'm not mistaken. Manipulation of patent but disease saphenous vein graft can result in embolization and native coronary circulation that result in morbidity and mortality. So patient with the previous aortic valve replacement can have difficult exposure with the mitral valve and going to anterior fixation. The best will be the anterior thoracotomy approach. And yes, this is the same picture before. So the right thoracotomy will be by anterior lateral thoracotomy through the fourth and fifth intercostal space. The first approach to this mitral, and it become the alternative for resternotomy, for mitral valve replacement especially. As I mentioned, that it will be from the fourth or fifth intercostal space, and the pericardium will be entered anterior to the phrenic nerve. See the picture, yeah. So will be the same as the picture. The patient will be in supine position. The hand will be below the head, so we can have good exposure. This is the incision. Will be in the fourth, fifth intercostal space of the rib. We'll take an incision, and this is the view. What will be like here, the right artery. TE will give us if there is atheroma in the descending aorta. If it's more than grade 3, that will be make it's contraindicated to cannulate, and then we will use the right axillary artery instead if it's more than grade 3. Venous cannulation will be performed through the femoral cannulation. That will reach up to the SVC. And if there is a tricuspid valve replacement, we'll push it more up to the IVC. Perfusing blood via cannula, for example, left ventricle vent, positioned across the mitral valve and into the left ventricle, will serve to displace residual air. Continuing with the thoracotomy, cardiopulmonary and time, blood loss, blood product usage, and lima injury rate has been lower in reoperative patients that undergoing right thoracotomy instead of the median sternotomy. If CABG or aortic valve is included, that will in favor with the median sternotomy. Otherwise, the right thoracotomy will be in the upper hand. So 90 patients undergoing reoperative mitral surgery and minimal invasive right thoracotomy was aortic cross clamp showed excellent results, which are as a 2% operative mortality was lower than in the SCS that predict mortality of 7%. 3 patients developed acute renal, only 3 patients developed acute renal failure postoperatively and requiring only new hemodialysis. 1 patient developed postoperative stroke, and no patient suffered from postoperative MI. So speaking of minimal invasive and port access right-sided technique, some authors have noted the distance of the mitral valve through the right thoracotomy approach. It can be very limiting. So in review of Duke University experience with the port access technique, in their series of 60 patients, 6 centimeter right anterior lateral thoracotomy was used with the standard port access technique. So of course, 45% of patients underwent cardiac arrest with endoclamp technique, whereas ventricular fibrillation was used in 55% of patients. Femoral cannulation was used for all patients, for sure. Cohort of patients undergoing reoperative sternotomy or right anterolateral thoracotomy. Patient undergoing the port access technique had lower mortality and decreased transfusion requirement. That was significantly longer with the cardiopulmonary time. So all reoperative patients through their recovery from this approach was rapid and less painful than the original sternotomy. And this is actually the main use of this alternative and the beauty of using the minimal invasive and less. So next, additional techniques for reoperative mitral surgery will be a bovine pericardial skirt. Will be like, let's see the picture. Yeah, this is the bovine. So the bovine skirt. Actually, it replaces the name if we see the lines. This is when we replace like the mitral valve, especially mechanical. So when placing the usual continuous fashion of technique of sutures, will take deep suture, but we need to be careful of taking that deep suture along with the left ventricle and replace like opposed to against each other like that. So it will be like a skirt and going all around. So this is another picture. Just when I'm saying take a deep stitch, you have to be careful, especially when you are taking it in the posterior part of the mitral, to not injure the left circumflex. What we can see here, the picture that patent circumflex here, and here with the injury postoperatively, we can clearly see that an ostial lesion, like there is no tributaries for the left circumflex. So back to the details of it. So as I mentioned, a pericardial skirt that can be fashioned with the sewing ring on the valve. Annular suture will be placed typical fashion through the sewing ring, and the valve is seated. So will be in the usual running fashion, continuous sutures along with the left atrium. In additional risk to this technique will be the atrioventricular disruption. Care must be used in removing the original valve when sewing ring, because it's frequently will be sucked in and intervened with the excessive annular tissue may occur. So we should take care of that for reoperative or following up the patient, that this technique that has been done for him. Aside from improved contractile function, disruption of posterior mitral annulus is avoided also. So David and his colleague found that the preservation of the subvalvular apparatus, and actually this is, I forgot to mention that this is the main purpose of this technique, is that the preservation of the subvalvular apparatus. So what David and his colleague found that 513 patients in reoperative mitral replacement, the preservation of the subvalvular apparatus accomplished in 103, which equal 21% patient with anterior and posterior preservation occurring. 31 patients which equal to 6%. Gore-Tex new caudal construction was performed in 135 reoperative mitral valve replacement, which equal 26%. Total preoperative mortality occurred in 3.6% of redo patients. with the preserved subvalvular apparatus, native tissue, and cortex reconstruction versus 13.3% of redo patient without preservation. So it was impressive result, which is really significant, and the p-value was less than 0.01 with the preservation of this subvalvular apparatus with this technique. So it should be considered. Is that clear? Can anyone answer me? Because doing the stuff is online is like, am I going good, too slow, too fast?
Go ahead.
Hello?
No, it's good. Continue, please.
Okay, thank you. So next will be the re-operative tricuspid valve surgery. Actually, nothing more to say about the tricuspid valve. Consider the previous valves. Only a few points that I will mention is what we can tell here is then in philosophy research, they found that 72%, which equal in 58 number, were re-operations. The overall operative mortality in this group was 22%, equal to 18. Risk factor for mortality included urgent versus emergent status. Their age was greater than 50 years. Functional etiology and elevated pulmonary artery pressure was there. Of the 60 survivors, 43% died during the follow-up. So it's really higher percent. The authors concluded that the patient requiring tricuspid valve replacement at high risk frequently at end-stage functional class, really. So continued sepsis from seeding, infective endocarditis, bacteremia, along with the antibiotic therapy, heart failure from the tricuspid insufficiency, along with the recurrent multiple pulmonary emboli, and are those the indication to intervene. So it should be something very active. Otherwise, the risk will be much higher. So that leads in their study to late onset of right-sided failure in the majority of these patients. So their follow-up was really poor. In another 20-year follow-up of originally reported series of 55 patients with intractable right-sided endocarditis who underwent tricuspid valvotomy without replacement, 4% died in post-operative period. The right-sided failure. Yes, Dr. Farid.
Did you say valvotomy?
Yes. Valvectomy, sorry. Valvectomy without replacement. 2 patients, or which equal 4%, died in post-operative period with the right-sided failure. 11% required prosthetic valve insertion in 2 days. Required prosthetic valve insertion from 2 days to 13 years later with the medically refractory treating with the heart failure. Of those who underwent the re-operation, 4, which equals 6%, died as such severe hepatic congestion and need of re-operative valve replacement. Without replacement, in this approach, some practitioners, they are very preserved. So an alternative treatment option to perform valvectomy followed by delayed valve replacement, it will be in 3 to 9 months later. So that will conclude my topics. I will just summary what I've mentioned, just to make it very concise and clear. Yes, please.
What's the rationale of valvectomy in those cases? Why?
It will be high risk with the patient, especially what we can see here with the previous.
So why not replacing the valve at the same time?
The tricuspid valve.
ما ابغى اضحك.
Look for the etiology. Why you took them to the OR first, Amjad? In the first place, they were taking to OR. Why?
In redo cases, we'll take them for
the etiology.
Depends on the etiology. Infective endocarditis, whatever thrombus.
Which group of patient? Regular group, drug abuser group.
Drug abuser, yes. Well, yeah, drug.
So drug abuser with high, because of the drug abuse one.
Okay. Addiction, yeah. There will be pre-operative. They will come up
out of destruction. Then you go back and replace the valve.
Yes. This is your point, Dr. Farid?
Yeah, just for you to think about it. Thank you.
Okay, thank you. So just as a summary for what I mentioned in all, for the whole topics, for imaging, we need to consider the multi-detector CT for avoiding the injury to the great vessels, relation of the sternum to the to plan your surgery as a re-operative. It's an essential. So this is the first thing that we can do. Risk factor will be, as I mentioned in the schedule, age, ejection fraction, heart failure, classes of NIHA, pre-operative shock, a kind of valves, prosthetic versus mechanical with endocarditis. All of those should be considered. In the operative valve surgery prior, yes.
Amjad? So you said something that إنك تحسب إنه this is the answer for Dr. Farid, right? That's what you said earlier?
Yes.
Okay, I warn everybody that whenever you hear somebody saying, I heard somebody says, or I think this is it, I think this is the best, this is not evidence, huh? فتبينوا. ما أبغى أقول على أمجد إنه فاسق ولكن الواحد لازم يتابع هذا الحديث، ها؟
طيب أمجد حبيبي، أمجد يلا عشان باقي لنا جونر كلوب we need to conclude لو سمحت.
اوكي يلا خلاص.
طيب تسمح لي بس تعليق بسيط.
دكتور خالد تفضل، ما نقدر نقول لك لا.
اي بالنسبه للستيج بروسيجر ولا سنجل ستيج بروسيجر فور انفكتيف اندوكاردايتس ان tricuspid valve, طبعا removing the valve and just leaving the valve without replacement, we have to make sure that we have a normal RB, we don't have a pulmonary hypertension, patient with the left side endocarditis, pulmonary hypertension, and those patients, they might do worse with a single stage procedure. As far as I know, there is no evidence of superiority for a single stage or two-stage procedures. I don't know, Dr. Farid, what do you think? But what I know that there is no difference between the single stage or two-stage procedure.
So the answer comes from experience with dealing with this kind of patients, اللي هم drug abusers. No matter what you do, they end up dying the majority end up dying within 1 year, usually related to the drug abuse or to related to gang killing. Somebody will kill them, stab them, shoot them, whatever. So what we did, and this is, again, there's no science here. This is this is experience I learned from the institute I was trained in. Drug abusers, we remove the valve and we observe the patient for 6 months. If he's off the drugs and if he's straight and he living clean life, then we proceed with the giving him a good chance.
تمام. طيب thank you.
طيب عشان الوقت شكرا جزيلا. أمجد خلاص.
Just a summary. It's a 12 points, so we have like 9 points to go. So pre-operative valve surgery after cabbage for patent Lima graft will be a decision to be taken regarding the intraoperative management must be made. Pre-operative root operation should be avoided if not indicated. Aortic valve surgery is a good alternative, as we said, in difficult cases. TAVR is the well-established technique in the operative valve replacement for high-risk patients, along with the valve-in-valve implantation. We should get use of it. Right thoracotomy approach in the mitral valve and tricuspid provided an excellent exposure. Most commonly, periopatetic leaks should be patched with the pericardial patch, then treated with the valve replacement if valve functioning is normal. Re-operative tricuspid valve occurs in high-risk patients, pulmonary hypertension with variable degrees with heart failure. So operation should be carefully considered. Re-operative valve surgery most commonly involve structural valve deterioration, as we mentioned in the beginning. Finally, the bioprosthetic valves also are known to undergo time-dependent process. So that will result in 15 years time period. And thank you. This is another schedule, just was for what I mentioned. Thank you. Any question, please?
يعطيك العافية أمجد.
Thank you very much, Amjad. You did a great job summarizing this long and complex chapter. Now, I think we have to proceed with the last session. Dr. Ahmed Salwood from King Faisal will present now a literature, not a literature review. I think a meta-analysis of restrictive versus liberal blood transfusion cardiac surgery. دكتور أحمد موجود؟
السلام عليكم جميعا.
السلام.
بس ممكن عليكم السلام.
أمجد بس ستوب شيرنج عشان أقدر أسوي شير سكرين.
Stop already. Stop already.
باقي ما أقدر أسوي شير سكرين.
Okay, try now.
Yeah.
Okay.
السلام عليكم. الصوت